Good evening, everybody. Welcome to this evening episode of Pursue 6C Liver and GI Pathology. And we are streaming live from Kolkata. And today, the topic for the day is liver neoplasm. And to talk on that, we have Dr. Bhaskar Mitra, who is an MBBS MD from Kolkata, a DNB gold medalist. And he's a consultant histopathologist from the famous Tribedi and Roy Diagnostic Laboratories. He's got multiple publications in international and national journals, and he is a reviewer of many journals. And today he shall be talking on liver neoplasm, and this will be session 1. But before we ask him to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. So with this, let me request Dr. Bhaskar sir, please share your screen and start presenting. Thank you. Yeah, I can see your screen. Just make it full screen, please.
Yes. Okay, I think I am audible to everybody, and also my presentation is visible.
Yes, yes, it is visible. Yeah. Please start. Yeah.
Okay. Today my topic is a liver neoplasm. Rather, I would say a liver mass. How we should approach to a liver mass. Okay, now there are variety of things in the liver. Some are pre-malignant, some are malignant, some are benign conditions, some are tumor-like things which usually present as a mass lesion in the liver. So today my topic is on the liver neoplasm. On today's topic, I will try, this is a vast thing, so I have divided this whole lecture into the two parts. Okay, today I will discuss more on the benign and the neoplastic-like lesions which we encounter in the liver, and then in the next class I will try to cover the malignant counterpart of this liver masses. Now, there are some areas which lies in between. That topic will be discussed both in this class and the next class, so we can follow the missing link among these two classes. Now, some basic things. This is the anatomy of the liver. We all know this is the right lobe, left lobe, position of the gallbladder and the vena cavas and etc. This is situated in the right hypochondrium, epigastric region, left hypochondrium. The well-known function of the liver, bile production and other enzyme activation, storage of glycogens, etc. Now, the liver has been divided into the following segmental anatomy by the different lobes. That is the lateral segment, lateral medial segment, anterior segment. It is better appreciated here how we separate the liver into the different lobes. These are the things we usually notice when we do particularly the autopsy specimen of the liver. Now, coming to the basic anatomy of the liver, particularly these things I escaping. Now, this one, the histomorphological anatomy, the liver lobules. From here, we will approach to the liver mass. Okay. So, what is hepatic lobules? It is the hexagonal lobules, we all know, centrally placed central vein. There are the cords of hepatocytes, and then the periphery, there is a situation of the portal tracts or portal triads. Okay, the duct artery vein, the combination, the bile ductal, hepatic artery and the portal vein. This is the combination. So this is the histomorphological picture of a liver showing a central vein in the center. From there, the cords of hepatocytes are run. Okay, in between the cords, there are the sinusoids, and in the periphery, there are the portal tracts. So, how this liver architecture is well maintained by the reticulin framework, which holds these cords of hepatocytes. Now, these are the basic important points we have to remember while we study a liver lesion, both in the inflammatory and in the neoplastic conditions. The first we describe whether this hepatic, any disturbance in the hepatic lobule is present or not. Now, to demonstrate or to objectively prove that there is a disturbance in the architecture of the liver, the reticulin stain is very important. Once the architecture of the liver is destroyed or disrupted, this reticulin framework gets first disrupted. Okay. Now, these are the pathogenic pathway how the liver lesions develop. Initially, there may be the pathogenic condition like different toxic materials, drugs, different viral infection that causes injury to the liver, and that injury may lead from acute to chronic liver disease where there is a simultaneously going on proliferation and necrosis and destruction of the liver hepatocytes. So on this there is a ongoing fibrosis going on which caused by this stellate cell activation. Ultimately, that led to the formation of the abnormal liver nodule, which was surrounded by extensive bands of fibrosis causing scarring. And this forms the nodules. Initially, up to this stage, we call these nodules as a hyperplastic nodules because till these positions, there are no genetic abnormality or instability. Henceforward, there starts the molecular genomic instability and transform these hyperplastic nodules to a dysplastic nodules. Over that, more and more genomic abnormality or instability like loss of P53 and many more are going on that causes the development of this dysplastic nodules into the malignancy or hepatocellular carcinomas. This may be well moderated or poorly differentiated. Now, how we approach these liver lesions? Some book shows this vast charts. They approach these cases as whether the lesions are solid or whether the lesions are cystic. If the lesions are solid, then which are the benign condition are we looking at? Liver adenoma, focal nodular hyperplasia, hemangiomas, adenomatous hyperplasia. These are the things. Cystic, it's a simple cyst or cystadenoma, carcinoma, bile duct cyst. If the lesion is solid, whether it is malignant, then comes the hepatocellular carcinoma, cholangiocarcinoma, all those carcinomas, lymphomas, this group. Or there may be small solid nodules that causes this metastatic tumors, multiple nodules. But I find this list and this approach a bit jumbled up. So it will be a bit difficult for those beginners to investigate those liver nodules. So I approached in a different way. Just going back to this slide. Okay, in a normal liver, what we are seeing? We are seeing two things, epithelial component and mesenchymal component. In the epithelial component, what we are seeing? Two things, hepatocytes and biliary duct epithelium cells forming the ducts. As such, no other epithelial cells are there. Okay. Now in the mesenchymal component, what we are seeing? We are seeing blood vessels, we are seeing fibrous tissues, we are sometimes seeing fats, sometimes other materials, different connective tissue materials. So my approach on this thing will be like this. So today we are talking about the benign tumors. So my approach is whether we are seeing any lesions or proliferation on the epithelial component or in the non-epithelial component. Okay. So on the epithelium, what we said is the two group. Is one hepatocellular group in which there is a proliferation of the hepatocytes, and another group there is a biliary duct epithelium or biliary proliferation. So this is another group. Here comes in the hepatocellular group these things: focal nodular hyperplasia, diffuse nodular hyperplasia, some regenerative nodules, okay, some dysplastic nodules, and then the hepatocellular adenomas. Okay. Now in the bile duct things, again the bile duct things can be divided into the biliary hematomas, biliary cystadenomas, then biliary duct adenomas. Okay, so this is the two group in the epithelial part. Now coming to the non-epithelial part, what I am saying in the mesenchymal component, whether there is a proliferation of the blood vessels group or muscle or adipose tissue, or there may be mixed proliferation of the different mesenchymal components. Okay. So in the blood vessels, this group caters the hemangiomas, different telangiectasias, borderline vascular tumors. Okay. In the muscle group, there are leiomyomas, rarely seen in the liver. In the adipose tissue, we got the hepatic lipomas. In the mixture group, we get a combination of the connective tissue components like angiomyolipomas, three components, and different many more. There are something that may present as a tumor-like lesions, like focal fatty lesions in the liver, pseudolymphomas, or mesenchymal hamartomas, that is the abnormal proliferation of this mesenchymal component. So on this approach, today I will going to address this liver neoplasm. Okay, so first I am going to this group, that is the epithelial tumors with a hepatocellular thing. So the first criteria is proliferation of the hepatocytes. Now first come is the focal nodular hyperplasia. This is one of the most common benign hepatic lesion. Usually occurs in the women about in the adult at 30 to 50 years age group. Now this is not a true neoplasm, as the name states. It's a focal nodular hyperplasia. So there is a proliferation of the hepatocytes, but it is not a true neoplasm, and therefore it has got a at least no risk of developing into the hepatocellular carcinoma. Now what is this thing? How this thing develops? Now initiating factor on this is a vascular anomaly or malformation. So suppose there is one blood vessel that get thrombosed, or that get damaged, or that may become anomalous due to developmental things, and the arterial feeding vessel that undergoes that becomes thrombosed. Now there is a proliferation of the myointimal layer, secondary myointimal proliferation, and the surrounding the blood vessel, the adjacent liver cells get atrophied due to hypoperfusion. Now there is a resulting regeneration on the surrounding hepatocytes, causing a bit of proliferation of that area, forming a focal nodular mass or focal nodular hyperplasia. This is the radiological finding. Here we can find there is a mass situated in the liver, well demarcated mass. Usually they are solitary, discrete, rounded mass with a pale, well delineated background normal liver. And the characteristic finding we found in these cases in the gross examination is the central stellate scar. Now, from the pathogenesis, we know that this is a blood vessel that get damaged, there is a hypoperfusion, so central area there is a fibrosis, so there is a scar formation. This stellate scar is one of the signature of this focal nodular hyperplasia. Now, when we see the microscopy, we cut the sections and see what we can see the stellate scars, and center of the scar usually contains a large dystrophic blood vessels, and most commonly it is dystrophic arteries with a thick walls. Now, benign hepatocellular nodules, these fibra radiating, there is a still a scar and there is a radiating fibrosis from this central pointed blood vessels, dividing the whole surrounding liver parenchyma into multiple segments like this. Okay, and here there is a proliferation of the plates of hepatocytes. But important thing, as I mentioned earlier, usually the reticulin stain holds the cords of hepatocyte, which is usually 1 to 2 cell thickness. Here it also holds this 2 cell thickness, not more than this. Okay. Now there is a both proliferation of the endothelial and some Kupffer cells are there. In the periphery of this, as this fibrous scarring is there is a distortion of the lobular architecture, and there in the periphery there may be presence of atypical ducts composed of flattened duct epithelium without proper lumen formation, which is also seen in this focal nodular hyperplasia. No interlobular bile duct can be appreciated, and as this is not a true neoplastic lesion, the cell doesn't show any significant atypia and they doesn't transform into a malignancy. So the characteristic finding is 1, 2, 3. First one, central fibrosis with a presence of dystrophic arteries, radiating fibrous tissue enclosing the lobules of hepatocytes. Within the lobules, the hepatocytes are 1 to 2 cell thick cords, and in the periphery there may be bile duct tubes, presence of bile duct tubes. There may be inflammation as there is obstruction. So here again the fibrosis there is the presence of blood vessels, and in which there is a lymphocytic infiltrate. Now again, this is a nodule. There is a proliferation of the hepatocytes surrounded by the fibrosis. Fibrous tissue is densely infiltrated by the lymphocytic infiltrate. In the periphery of the lobules, there is a proliferation of this bile ductules. These are cuboidal to flattened, ill-formed bile ductules. Sometimes they could not be well appreciated in the H&E stains. If we do a CK7 on this bile ductular epithelium will be well highlighted on this fibrous tissue. Now, coming to the immunohistochemistry part of this focal nodular hyperplasia case shows, if we stain it with the glutamine synthetase, it shows a map-like pattern. In the perivenular areas, they show absence of this glutathione synthesis, but in the periphery, there is a positive staining of this glutathione synthesis stain. At the same time, the normal liver tissue doesn't show the glutathione synthesis expression. This shows the CK7 expression on the different small bile ductules around this liver nodules. Again, the glutathione synthetase, this is very helpful in cases of true cut biopsy, where this sometimes in the true cut biopsy, the focal nodular hyperplasia may be missed, and this can be demonstrated best by the glutathione synthetase stain. Now coming to the another hyperplastic condition is nodular regenerative hyperplasia. There are multiple solitary or multiple nodules throughout the liver. Sometimes if it is present multiple and present throughout the liver, we call it diffuse nodular hyperplasia. Nodular regenerative hyperplasia. This is a tumor-like lesion. And important things, this we see in a setting of cirrhosis. It usually seen in the adult population. It can be associated with different hematological abnormalities, different neoplasm, chlorogen vascular disease, or in non-cirrhotic condition like pre-sinusoidal portal hypertension may show nodular regenerative hyperplasia. These are usually single or multiple, usually found in a backdrop of a cirrhotic liver. This is a cirrhotic liver showing the bands of fibrosis enclosing the nodules of liver tissue. They are usually well circumscribed, as we can see in this picture. with firm white gray in color. It may be size of a pinpoint from 2 5 millimeter to 1 centimeter in length. Can involve one whole liver, entire liver. But when you see the reticulin pattern, again we can see this cell thickness is 1 to 2 cell layer thickness. So again cell thickness is less than 2 or less than 3, what we can say. Now, sometimes the fibrosis is prominent in the backdrop, and but sometimes there may be ill to well demarcated proliferation of a hydrophic hepatocyte can be seen within the lobules. This is the nest of hydrophic hepatocytes that can be seen within the lobule that compresses the adjacent hepatic cords and sinusoid. Again, this can, in the reticulin stain, it can be 2 cell layer thick. It may be on the side and causes bulging of the liver surface, which is again can be better appreciated on the reticulin stain. The adjacent portal tracts and the liver parenchyma usually are remarkable, and the nodules are composed of what we say the benign hepatocytes. The cytologically they do not show any significant atypia or regenerative change, atypia or significant increase in the mitotic activity. Now, these two are the hyperplastic condition, the previously what we had I have discussed. They are showing, if we see the clonality, they are the polyclonal nature of the hepatocytes. Now, coming to the monoclonal proliferation of the hepatocytes. As the name suggests, monoclonal proliferation, so it has to be a tumor, neoplastic condition. So first comes the hepatocellular adenoma. It's a benign liver neoplasm. It is strongly associated with oral contraceptive use, androgen steroid therapy, associated with diabetes mellitus. And there is one thing. There is a definite genetic abnormality behind which causes the proliferation of this hepatocytes. The pathogenesis may be multifactorial, but the adenomas are usually monoclonal. So, some of these hepatocellular adenomas have a chance of transformation to the hepatocellular carcinoma. Now, according to the genetic alteration and the mutations, the hepatic adenomas can be divided into the following subclassifications. First is hepatocyte nuclear factor 1 alpha inactivated hepatocellular adenoma. Next is the inflammatory hepatocellular adenoma. There is abnormality in the serum amyloid A and C reactive proteins. There may be beta-catenin activated mutations causing hepatocellular and adenomas, which is one of the most important groups. There may be combination of inflammatory hepatocellular adenomas along with beta-catenin activated mutation. There may be uncalcified group which doesn't follow this specific genetic or alteration or mutation. Now, on macroscopy, they are usually solitary, maybe sizes up to 30 centimeter. It's a quite large tumor. Okay, there may be numerous nodules of this hepatoadenoma that may be solitary, that may be multiple, involving both the lobes. If it is more than 5, we term it as a hepatocellular adenomatosis. This is a soft grey tan brown color delineated with little or no fibrous tissue on this adenomas. There may be heterogeneous areas of necrosis and hemorrhage. Now, again in this thing we can see these are the proliferation of the hepatocytes. They are again it's a benign neoplasm, so the proliferation of the benign hepatocytes, they having small nuclei and nucleoli, 1 to 2 cell layer thickness. Sometimes some cases may show minimally increased NC ratio. The hepatocellular cords are 1 to 2 cell layer thickness. This is a hepatocellular adenoma, and this is a hepatocellular carcinoma. More cell cords are there, so in comparison the reticulin network is well maintained here. It may show presence of fatty steatotic changes within the hepatocytes with mixed inflammatory infiltrate in the different types. There may be presence of accumulation of a bile within the hepatocytes, or maybe small formation of the bile legs within those hepatocytic cords. These are the microscopic features usually we see in the hepatocellular adenoma. Now, these are the genetic mutations what we are looking for. First is HNF1 alpha mutated. There is a somatic or genomic mutation that is involving the CYP1B1, MOT3, the beta-catenin activating or CTNB1 activating or deletioning mutation. There may be mutation in the exon 3. There may be mutation in the exon 3S45, and there may be mutation in the exon 7-8 mutated. Now, these mutations lead to the different level of activations of the beta-catenin. This 7 to 8 mutation, they show weak activation. This shows moderate, and the exon 3 shows high level of activation of the beta-catenin. Okay. Now, inflammatory group, there may be exon 3 or exon 7-8 involvement. There is one pathway is sonic hedgehog pathway, and another is the unclassified pathway. Among this, most important is the exon 3 mutated one. Now, coming to the details of this. Now, first is the hepatocyte nuclear factor 1 alpha, what I am saying. There is morphologically, I will be going details of this. Steatosis, the variable degree or little or absent inflammation. Steatosis of variable degree, little or absent inflammation. There may be no cytological atypia. These nodules are lacking the liver fatty acid binding protein expressions. Inflammatory one, as the name suggests, there is a very prominent lymphocytic infiltrate, and there is a increase in the sinusoidal dilatation and giving rise to a paleotic type of changes in the liver and showing the telangiectasia. There may be bile ductular reaction. There may be overexpression of this inflammatory protein like C-reactive proteins, serum amyloid associated proteins like this. The beta-catenin activated mutation, what I see is when there is an activation of this beta-catenin mutation, there will be activation of the WNT beta-catenin pathway. That leads to the increased carcinogenesis of these cells. Some say these are the missing links. So, from hepatocellular adenoma to hepatocellular carcinoma. So, they show some amount of cytological atypia, pseudoacinar formation, and there is a chances to development of hepatocellular carcinoma is more. As there is a beta-catenin activation, there is an overexpression of this beta-catenin and glutathione synthesis. Now, why we should know this? Because we have to differentiate this beta-catenin activated mutation induced hepatocellular adenomas from the other one. How we can differentiate it? Because what I have said shows a strong nuclear staining of beta-catenin and strong staining overexpression of glutathione synthesis. Glutamine synthesis, sorry. Now, overall, normally the transformation of hepatocellular carcinoma from hepatocellular adenoma is 4.2%, but in the beta-catenin activated subgroup, it increases from 31 to 46%. And other groups rarely transform into malignant, but this beta-catenin activated group usually transform it. Now, coming to the individual thing, this is HNF1 alpha inactivated things. These cells, this hepatocellular adenoma proliferation shows marked steatotic changes and increased glycogen content. This cell shows no cytological atypia, minimal inflammatory infiltrate to no infiltrate. There is a genomic activation and loss of liver fatty acid binding protein. So there is a loss of liver fatty acid binding protein in this case. This is the adenoma part, which showing some amount of loss, usually seen in the younger patients and may be associated with diabetes. This is again HNF1 alpha mutated one showing marked steatotic changes with minimum inflammatory activity. If we stain with LFAB immunohistochemistry showing normal liver with strong diffuse staining of this LFAB immunohistochemistry positivity, but here in the hepatic adenoma part it is negative. Now beta-catenin mutated one, it is more common on the males. It activates the WNT beta-catenin pathway and they show characteristic cytological atypia, pseudoglandular or pseudoacinar pattern, as the morphology will tending towards formation of an hepatocellular carcinoma. Therefore, some people call this as a borderline lesion and a missing link between the hepatocellular adenomas and the hepatocellular carcinomas. And some also call them as atypical adenomas because they have got a higher risk of malignant transformation. Now they shows the nuclear and even the cytoplasmic membrane expressions of beta-catenin and strong expression of glutamine synthesis, which in the focal nodular hyperplasia part we have seen a map-like pattern where the perivenular areas are a bit showing a patchy positivity in some areas, some not, but in the hepatic adenoma, particularly the beta-catenin mutated one, they show strong and diffuse staining of glutamine synthesis as seen in this picture. Now, hepatocellular adenomas with inflammatory and telangiectatic type. Now the name suggests it has an inflammatory component and a telangiectatic component. So where here we can see the increased inflammatory markers, like this markers, they usually occurs of insulin resistant patients, overweighted, obese patients. Now the liver shows this chronic inflamed and a paleotic telangiectatic things. Now here I first explain what is the term paleotic suggests. Paleotic means there is a ill-formed vascular spaces that do not line by the sinusoids. There are hepatocytes are there. The proliferations of the blood vessels containing the RBCs and everything, and it looks like a telangiectatic vascular spaces throughout the lesion that can be seen. There is an increased inflammation on this. There may be small bile ductular-like areas that was surrounded by dense inflammatory lymphocytic infiltrate that can be seen here. Again, there is a paleotic-like areas. Here, there may be small ectatic blood vessels, small thin-walled ectatic blood vessels can be seen, which is hemorrhagic. Again, amount of inflammatory infiltrate. Individual hepatocytes shows hydropic or may sometimes show steatotic changes. Ectatic blood vessels are there, and there is a characteristic Mallory ring bodies can be seen in this degenerated hepatocytes. Now this inflammatory hepatocytes showing telangiectatic areas and inflammatory infiltrates, they show strong expression of serum amyloid precursor proteins. Their C-reactive proteins immunohistochemistry with CRP shows strong and diffuse positivity in these cells. Serum amyloid A protein immunohistochemistry expression of these cells on these nodules. Now overall to the things, the first this one, the most important one, the beta-catenin exon 3 mutated one shows strong nuclear and cytoplasmic beta-catenin and diffuse expression of glutamine synthesis. These are the borderline histology. and showing cellular atrophy. These are the highest rates of progression to the hepatocellular carcinoma. Now, the beta-catenin exon 7/8 mutation, as we shown in the previous one, they shows the weak activation of the beta-catenin. So, the nuclear staining with beta-catenin they do not show, and they usually do not have a high risk of transforming to the hepatocellular carcinoma. So, as the mutation on the exon 3 is there is the increased expression of the strong expression of the beta-catenin mutation, and they show strong expression of the beta-catenin on immunohistochemistry, and they has got a more chance of developing into the hepatocellular carcinoma. Now the inflammatory hepatocellular adenomas, they pass through the JAK-STAT pathway. The other inflammatory ones, they are some amount of inflammatory infiltrate is there. Now the sonic hedgehog hepatocellular adenomas shows gene fusion between INHBE and GLI-G, showing increased expression of prostaglandin D synthetase, and they show diffuse activity of this expression and lack of the activity of the liver fatty acid binding proteins. And the unclassified group do not show any specific genotype and do not show any specific phenotypic picture. So in case of hepatocellular adenomas, if we use a panel of antibodies, immunohistochemistry, which is very less frequently utilized in very small, very large centers, they can do this, but very not commonly available in the most of the laboratories. If they do the liver fatty acid binding proteins, serum FA and CRP, glutamine synthesis, and beta-catenin. The beta-catenin activator one shows small, strong nuclear expression and diffuse positivity of glutamine synthesis. This is one group. Inflammatory one goes with a strong expression of these two proteins. Okay. Unclassified ones looks different. Now the focal nodular hyperplasia shows positive staining with LFAB-V1, and there is a patchy pattern of the glutamine irregular anastomosing map-like pattern. In the normal liver, LFAB is the positive, and it is glutamine synthesis is around the central venous area. So the important thing is nuclear expression, beta-catenin here, this one, this SASCRP in the inflammatory group, and the glutathione anastomosing map-like pattern in the FNH. So this is a differential chart showing the differences of the focal nodular hyperplasia, hepatocellular adenoma telangiectatic type, conventional one, comparison with the hepatocellular carcinoma group. Here the focal nodular one, they show characteristic central scar. This all shows some nodular appearance. Characteristic central scar on the gross examination. Hepatocellular carcinoma, particularly the fibrolamellar variant, can also show this stellate scar. Fibrous band is common in the focal nodular hyperplasia, usually not seen in these cases. Hemorrhage infection is usually seen in this telangiectatic group as more blood vessels are there. Hepatocyte shows hyperplastic, more the cell cord thickness is more than 3 cell layers. Here all are less than 3. Mitosis is more common here, steatosis is there, and the more other markers are also positive in this hepatocellular groups. So these are the features which differentiated the focal nodular hyperplasia from the other groups. Now, characteristical finding to differentiate between hepatocellular adenomas versus hepatocellular carcinomas. Hepatocellular carcinoma shows thickened cell plate, loss of reticulin network. Hepatocellular adenoma less than 1 to 2, it disrupted. Cytological atypia and mitosis is more. Pseudoacinar and the pseudoglandular architecture is more commonly seen in the hepatocellular carcinomas. In the marker, they show glypican-3 positivity in the malignancy, HSP70 positivity, heat shock proteins, glutamine synthesis diffuse positivity. In the benign, they show patchy and focal positivity, except for the beta-catenin one, which shows diffuse. The Ki67 and the PCNA shows high proliferation index in cases of malignancy as usual. The hepatocellular adenoma and the focal nodular hyperplasia, sometimes this may be difficult to differentiate, but this stellate scar is more, fibrous scar is more common in the focal nodule fissure, and in the immunohistochemistry part, the hepatocellular adenomas, they are negative for this, lacking this LFA-BP, which is positive in cases of focal nodular hyperplasia. This inflammatory markers in the inflammatory hepatocellular adenomas are common, which is negative here. Glutamine synthetase shows diffuse staining in case of beta-catenin, map-like here in the focal nodular hyperplasia. And the DNA clonality, if we do the clonality, the it's a hepatocellular adenoma is a monoclonal thing, as it's a tumors, and usually the focal nodular hyperplasia is a polyclonal thing. Now coming to the backdrop of a cirrhotic liver, the large regenerative nodule, as I previously discussed, the diffuse regenerative nodules or in regenerative nodular hyperplasia. Here comes the another two things, that is the low grade and the high grade dysplastic nodules. Now, what is the dysplastic nodules? Dysplastic nodule is a precancerous condition. It is a missing link from hepatocellular adenomas, hepatocellular nodular proliferation reactive to benign proliferation to carcinomas. Now, how they move to carcinomas? They take two steps add-on. First, the induction of the arterial blood supply and the stromal invasion. Now, during this process, the dysplastic cells, they acquire some characteristic things. That is, first is the small cell changes, another is the large cell changes. In the small cell changes, the cells, hepatocytes, they have got a decreased cytoplasmic volume. They show increased cytoplasmic basophilia, nuclear pleomorphism, hyperchromasia, and high NC ratio. So cell size are a bit decreased, but the nuclear chromasia and the NC ratios become more increased. The cells are more towards the malignant cellular architecture things. Now in the large cell changes, these things are less. Now if this dysplastic nodules are less than 1 millimeter, we call it dysplastic focus. Now in our next class, when we discuss this pre-malignant condition and transformation into hepatocellular carcinoma, I will go details of this. Now I will concentrate on these things, that is the large regenerative nodules, or previously known as macro-regenerative nodules or adenomatous hyperplasia. Here represents a large nodules larger than 5 mm in diameter. These are usually seen in the macronodular cirrhosis. This nodules lacks the cytological atypia or architectural atypia, and the hepatocytes may show the oncocytic changes and sometimes the small or large cell changes. The portal tags may be seen in this large regenerative nodules. This is the dysplastic nodules. Dysplastic nodules. This, as I said, this is a dysplastic nodule showing extensive small cell changes, showing high architectural atypia. The cell plates are increased, the course number, that is up to 3 cell layer thickness, but not more than this. May show pseudogandular architecture. Sometimes there may be expansion subnodule with marked atypia are seen within these nodules. They are termed as nodule in nodule appearance. These are nothing but the well-differentiated hepatocellular carcinoma developing in a high-grade nodules. These high-grade dysplastic nodules shows a bit more cytological and architectural atypia. Now, sometimes small hepatocellular carcinomas up to 2 cm diameter can be seen as a small nodules that may be misconfused with this benign lesion. They may be distinct nodular type or vaguely nodular type. Now, distinct nodular type, the name suggests there is another name to this, is progressed hepatocellular carcinomas. These are moderately differentiated nodules of hepatocytes which lacks the portal stacks and show evidence of microvascular invasion like this. These are the moderately differentiated nodules of hepatocytes. They are showing distinct nodularity surrounded by the bands of fibrous tissue around this, and there is an inflammatory infiltrate. They are biologically more advanced and usually higher rate of transforming into the typical hepatocellular carcinoma. They contain an important thing, the vascular game, they contains its own blood supply, own from its arteries. Another is the vaguely nodular hepatocellular carcinoma, also known as early hepatocellular carcinoma. These are well differentiated tumors. These are the well differentiated ones. They lack the distinct fibrous tissue at the periphery, so they are vaguely nodular. Here the cells shows more of a large cell changes. They may show presence of portal tracts within this, and this may be entrapped portal stacks because they are encroaching, showing stromal invasion. So these are the two things, that is the vaguely nodular, also known as the early hepatocellular carcinomas, and the small cell progressed hepatocellular carcinoma. This can be sometimes difficult in differentiating from the others. These are the things. Now, so dividing this thing into a flow chart, if we see a hepatocytic proliferation, is this a benign hepatocytic proliferation or a malignant? If it is a benign hepatocytic proliferation with the presence of portal tracts and proliferated bile ducts and in the periphery with the spinous scar, we consider this as a focal nodular hyperplasia. If the fibrous septa is not there, bile ductular proliferation is there, only nodules of hepatocyte, we consider this as a hepatic adenoma. If it is a malignant and showing hepatocytes showing more and more cytological atypia, we might be dealing with a hepatocellular carcinoma. And if the hepatocyte resembles the fetal liver tissues, we may be dealing with a case of hepatoblastoma. So this is about the hepatocytic proliferation. Now coming to the biliary proliferation. Now for biliary, I tried to approach it like this. The biliary proliferation, it may be cystic, it may be solid. Solid doesn't mean it's a solid, it's more like a honeycomb-like. But still I consider this as a solid. Now this is a cystic. Now if it's cystic, is it a single cyst or a multicyst? Single loculated cyst, then we might be dealing with some developmental cyst. If it is multi-loculated cyst, is it lined by single cell lining? Then we are probably dealing with biliary cyst adenomas. If it is a multiple cell layer with a stromal invasion, we may be dealing with a cyst adenocarcinoma. Now coming to the solid part, cells showing no cytological atypia, solitary small closed ducts proliferated, we are maybe dealing with bile duct hamartoma. It may be multifocal with dilated ducts, disoriented ducts, but benign looking, no cytological atypia, we might be dealing with a bile duct hamartoma. If there is a cytological atypia along with the stromal invasion, we might be dealing with a cholangiocarcinoma. So on this backdrop, we will discuss. Now first, a single cystic lesion in the liver. Okay. Now we have to see what it is. If it has a biliary communication, fine. Otherwise, we have to look at the line. Is it lined by ciliated or pseudo-stratified columnar epithelium? And then followed by this, if it is there is a presence of a connective tissue followed by a muscle layer and again the outermost fibrous tissue, it almost mimics like a gut. So it's a ciliated hepatic foregut cyst. It's a developmental cyst. So in a cystic lesion with a smooth muscle in the wall, we might be developing with a hepatic foregut cyst. Now, if Again a solitary duct cyst, unilocular, lined by a single layer of cuboidal biliary epithelium lining, flattened biliary lining, and surrounded by fibrous tissue. No muscle is there. So we might be dealing with a solitary bile duct cyst. Sometimes this has another thing comes into the DD if the cyst is situated on the periphery, that is the mesothelial cyst. Mesothelial cyst may look like same flattened lining, same fibrous tissue, but they show typical mesothelial marker staining. And this shows the biliary epithelial marker staining, that is the CK7, CK19. CK7 may be positive also in the mesothelium, but the other markers like calretin, NWT1, these are positive on the mesothelial side. Now coming to the solid part. Solid, no cytological atypia, but it's not solid. It's like a honeycomb or tubriform like areas. This is distorted glands composed of distorted ducts, irregular, but minutely look at this, they have got an open lumen containing the bile. So we here dealing with a bile duct hematoma. This usually multiple. They occur maybe in the cirrhotic liver. Incidentally, the surgeons remove them as a metastatic nodule. They consider there is a single or multiple nodule in the liver. They remove it as a metastatic focus in conjunction with some other carcinomas. And in the histopatology, we find this ductules, benign looking cellular lining, open lumen containing biles. These are the bile duct hematomas. Now coming to the well-defined firm white lesions, particularly the subcapsular location, showing BRAF V6 and AD mutations. They are the proliferation of a small tubules or ducts embedded in a variable desmoplastic fibrostoma. The cells usually single lining, they lack the cellular atypia and lying in a desmoplastic fibrostoma. Here usually the luminas are not dilated and doesn't contain the bile. This is the differential with the bile duct hematoma. Now they may sometimes show the clear cell changes or oncocytic changes. Here we are dealing with the bile duct adenomas. Okay. Now sometimes there may be small bile ductules showing a typical clear cell changes. They usually are variety subtype of the bile duct adenomas. They are called clear cell bile duct adenomas. Sometimes they may form less well circumscribed and colonize in the hepatic parenchymas. Now from this till date we showing the bile ductular proliferation only. Now along with the bile duct there is a proliferation of the fibrotic stroma also. So the name suggests the term biliary adenofibromas because there is a tubulocystic biliary epithelial proliferation along with a prominent fibroblastic stromal component mostly composed of spindle-shaped myofibroblasts. They usually do not show any mucil production. They are typically biliary epithelium. Apocrine sounds may be present there. There is an amplification of CCND1 and ERBB2 mutation in this. This duct epithelium shows biliary type of phenotype like CK7, EMA and CK19.19 positivity. They usually benign but sometimes they show increased nuclear hyperchromasia and the pseudostratification may show complex papillary proliferation or cubiform architecture in the different areas. Now, next comes the hepatobiliary cyst adenomas. Cyst adenoma is a benign intrahepatic multiloculated biliary cystic tumors occurs in the middle-aged women. They usually multilocated. They may show a prominent mesenchymal stroma or with or without mesenchymal stromal component. The cysts are lining by the trabeculated papillary epithelium, papillary-like lining. Initially, it was known as bile duct papillomas or papillomatosis. Here, single layer of epithelium lying in a bile ductular stroma, as a single layer of epithelium lying, and there is a ovarian type of mesenchymal stroma is there. They are non-situated columnar epithelium, can be cuboidal. They may show mucinous changes with a mucicarmine stain positivity. They may be serous. Sometimes they show intestinal type of epithelium with goblet cell changes. If the lining is biliary type, then show CK719 positivity. If it is intestinal type, they show 20 and CDX2 positivity. And the stroma shows strong positivity for the SMA, viamentin, ERPR, even inhibit. Usually they do not show cytological atypia when it's a cystadenoma, but if it increases the cytological atypia, more stratification, it may ultimately lead to carcinoma in situ, ultimately into the invasive biliary cystadenocarcinoma. These are cystadenomas, the typical stroma, the lining epithelium showing biliary cystadenomas. Now coming to the non-epithelial group, that is the mesenchymal group. The first is the blood vessels, that is the hemangiomas, hepatic hemangiomas. The hemangiomas, they show soft reddish purple to bluish masses with a dilated vascular things with a blood clots within this. There may be hyalinization and fibrosis within this, giving rise to sclerosis. These are the dilated blood vessels containing blood lined by endothelial lining, single layer of endothelial lining. Some termed it cavernous hemangioma, but it interchangeably used as hepatic hemangiomas also, because most of the liver hemangiomas are cavernous type. These are the sclerosed hemangiomas showing sclerosis in the different areas. They may show diffuse angiomatosis, hemangiomas. Now, there may be borderline vascular proliferation like epithelioid hemangioendothelioma. They show small vessels with a periphery showing more cellular areas, and the central is the hypocellular areas, which are sclerotic, may be calcified. In between things are stroma, may be myxoid in cells. The individual tumor cells shows a dendritic type of appearance or epithelioid appearance, may show signet ring style of cells. These are low-grade malignant vascular neoplasm. Now, this is a vascular lesion occurs in the liver. This is called paleosis hepatis. They are presence of blood-filled cystic spaces separated by cords of normal hepatocytes. Here the typical lining is absent. They are mainly lined by the randomly distributed the hepatic parenchymal cells. Now they show hemorrhage rupture in the different areas. These are the differentiation point between the different vascular lesions. Now sometimes the liver may show focal fatty changes. This is metamorphogenesis due to unknown etiology, and in the CT or ultrasound they marked it as a lesion. Here may show the collection of hepatocytes, focal fatty changes due to some vascular anomalies. They may be shown in the ultrasound or CT scan, leading to a nature of the vascular masses, but they are focal metamorphogenic changes, not so tumors. There may be combination of the different connective tissues like angiomyolipomas. They usually show varying proportion of the blood vessels, smooth muscles and mature adipose tissue. As in other areas of the blood vessels, they show those typical epithelioid cells. Here in the polygonal cells, they show the typical immunohistochemistry pattern of HMB45, S100 and SMA positivity in those cells. If there is a hematopoietic element is there, we consider this as myelolipomas. There are pseudolipomas. These are not lipomas actually. They are benign degenerative lipomatous lesion on the surface of the liver that may be due to the detached colonic fat they adhere with it and causing undergoing necrosis and calcification and surrounded by a fibrous capsule giving rise to a pseudolipoma-like appearance here. The pseudocapsule is forming here and this fat cells showing degenerative changes. This showing the pseudolipoma-like appearance. Sometimes some hepatocellular adenomas or carcinomas may show this extensive fatty changes giving rise to a lipomatous lesion-like appearance. So these are the different lipomatous things on the liver like angiomyolipoma, pseudolipoma, myelolipoma, focal fatty changes. And last, that is the mesenchymal hematoma. This is an uncommon thing. They usually present in the childhood as a gelatinous mass of bile. There may be abnormal ducts or ductular proliferation along with the mesenchymal and the vascular proliferation is there. They usually lie in small ductular cystic spaces in a loose connective tissue stemma with a myxoid change and hemorrhagic changes at areas. To summarize my today's talk, suppose if we see a nodule, okay, first we see whether it's a hepatocytic or it's a biliary. If it's hepatocytic, we can approach it like this, whether it's in the cirrhotic background or the non-cirrhotic background. If it's a non-cirrhotic background, then we may consider this as a FNH and hepatic adenomas. Then proceed accordingly, look for those typical stellate scars, blood vessels within it, hepatic adenomas, the typical pictures of paleotic changes, telangiectatic changes, hepatic adenoma like steatosis, this and ultimately the different genetic mutation. If it is on the cirrhotic background, either it can be a non-neoplastic regenerative nodular hyperplasia or a dysplastic nodule. If it is a dysplastic nodule, then we will definitely look for the presence of small amount of nodule in nodule hepatocellular carcinoma in it. We can approach it like that. Or in other ways, another school of thought, we can start with the reticulin stain. What is the architecture? In the reticulin stain, what is the hepatic core thickness? If it is less than 2 to 3, again we can consider FNH, regenerative hyperplasia or hepatocellular adenoma in it. If it is more than 3 cell layer, then we will definitely go for the hepatocellular carcinoma group. So, on this two different approach, we can approach this liver lesions and for the biliary lesions, for the biliary lesions, this one is more convenient. This cystic and solid appearance, unilocular, look for the developmental cyst, whether there is in the wall there is a muscle is there, then it look like gut, foregut cyst. If it is only fibrous tissue, look for the bile ductular cyst or mesenteric cyst like that. Then multilocular, single cell layer, biliary cystadenoma, multiple cell layer with stromal invasion. And in the solid, there may be bile duct adenomas or bile duct hematomas. Okay, and the cytological atypia if is there, then it is the cytological atypia is there, then the cholangiocarcinoma is definitely on the bed. So for this hepatocellular masses, we can approach for the benign lesions, we can approach like this. And this is the algorithm which usually followed by the clinician for the focal liver lesions. If there is a risk factor for the hepatocellular carcinoma, elevated tumor markers, yes, then due to the dynamic CT MRI, look for hepatocellular carcinoma, metastasis and others. If no incidental finding, it may be solid or cystic or maybe hemangioma. Then again look for the central scar, FNH and hepatocellular adenoma. Cystic, asymptomatic, observe, and the symptomatic control invest, and there also comes the different abscesses and cystic infection which also lead to formation of the different nodules or cystic lesions in the liver, like hydatid cysts, hepatocellular hepatic abscesses, MBBS, that may also lead to this liver mass formation. Thank you, and in my next class I will continue with the malignant liver lesions.
Thank you, Dr. Bhaskar. Excellent talk. Very nicely done. I am very much impressed with your algorithms. The algorithms were very good, and I think that is a trick. The only difficult part of this entire analytical aspect of liver tissue is that when you get the entire liver or
yes,
a big
that
chunk
is,
of liver, then life is much simpler. But in majority of cases, we are getting true cut liver biopsies, and that makes life really difficult. But then the algorithms which I have put forward are very good. It's advised that everybody should follow those algorithms, especially the bile duct algorithm was very nice. I mean, it was very nicely done, and that makes life very simple. So we hope to see you in the next lecture in GI, which will be on malignant liver lesions. Isn't that right?
Yes.
Right. So now then, thank you so much. It was a very nice presentation, excellently done. Thank you. God bless you. Bye bye.
Thank you, sir. Thank you.